What I want to talk a little bit about today is this building on your progress and the national, a little bit about the national strategy, and then the focus really on how do we make it real and transform our various systems. I will say that as you all have been talking about, California has done a really remarkable job of expanding and continuing to extend the idea of systems and services for young people and their families. Just a few of those things, and you all know them better than I. It's just that as a reminder that we are building, and you are building on tremendous amounts of progress that we've had here in California and across the nation. Here we have the realignment of our mental health resources. Of course, Prop 63 back in the day was a pretty significant activity, but we also now have 2083. And then when I was hearing before, I was very excited about our superintendent from and the early childhood work that's happening in Yolo County. We also know that El Dorado County has a new children's commission, and of course I miss hundreds of other things that are happening. It's just that looking at what's going on in California and the strategies that you are looking at, and the whole idea of this conference about breaking the barriers down. My focus is a lot about integrating care. I do want to highlight a couple of things. One would be to recognize the Children and Youth Behavioral Health Initiative, the CYBHI initiative, and what's happening there. I heard before the transformation, the T-squared approach that's happening with the 4 pilot sites. That's very exciting. I also want to acknowledge the young people that certainly were here yesterday and that we're talking. As my bio talks about, one of the greatest honors that I had as part of my work at SAMHSA was helping to create and fund and sustain the organization called Youth Move, which stands for Youth Motivating Others Through Voices of Experience. It's now a national organization, a technical assistance for peer support and peer activities. I was very proud of them a number of years ago. They got their first ever SAMHSA grant, which was pretty cool, and with now over 70 chapters across the country. And we also have a number of folks here at this conference that I think have been building on those as champions that are doing this amazing work. So it's important to remember because, when we're in the middle and we're sort of slogging through our day-to-day activities, it's hard to remember that the difference that you make every day that you're doing this work, whether it's with a specific child or student, whether it's with a family, whether it's within your county or your state or nationally or, even globally, that difference that you make actually makes a significant difference. You do a major amount of work, and even when we move the needle, a thousandth of an inch, that in and of itself can make a huge change for some child and family. And I really feel that going forward here, just knowing that those incremental steps that you take, it doesn't have to be, a massive change. They can be very small or very incremental activities that make a huge difference going forward, especially in the lives of individual children and families. We all know this, and I thought that I would just spend a few minutes reminding ourselves about the importance of the data. We had a little activity on November 5th, and some of us that had been part of the former administration and stuff were a little taken aback. And at the same time, we also know, and working in state government and even in the federal government, I've worked for Democrats, I've worked for Republicans, and honestly, I personally don't care which side you lean on as long as you care about children and their families. And we do that by continuing to harp on the critical importance of the work we do and incorporating the data pieces that are so necessary to get the justification for, so that our funding, which will be at risk, is not as at risk, which means that we have to fight every day. And when I was hearing and speaking with some of the young people earlier, their passion and it just is so heartwarming, and it really is energizing to do this work when we know that there are leaders that are out there, our young leaders, our emerging leaders as well, that are going to continue to help us make a difference. You all can look at the statistics. We know that upwards of 20% of our young people have a diagnosable mental or emotional or behavioral disorder, and that at least 1 in 10 of our young people have a disorder as serious enough to qualify for what the federal definition is for a serious emotional disturbance. I'm glad you guys got that changed here in California. The young people really don't like that name. Would you like it if they talked with you about you having a serious emotional disturbance? I don't think so. We all have challenges. All of our families have challenges. But what that means ultimately is that 7.4 million children in this country have a diagnosable condition that is so serious that it impacts their ability to function either at home, at school, or in their communities. We know that our young people are faced with serious substance abuse issues. And the one thing I wanted to highlight on this particular slide is that the data are clear. Half of all mental illnesses are manifested or emerge or can be identified by the time a young person turns 14 years old. 75% by the time a young person is 24 years old, which means really, and this is something that we have to remind our policymakers all the time, that mental illness is a pediatric illness. And for the most part, when we intervene early and when we can change trajectory of a young person at a younger age, or we create the preventive programs that are always on the chopping block when funds get tight, but that's the way that we do it. If we wait until every child, all 7.4 million children, become so seriously challenged, then we've waited too long. We also know that we love evidence-based practices, and they're great. And at the same time, we know that it takes almost 18 years for a practice to go from an idea into actual implementation. And when you think about 18 years, that's an entire generation that we've lost. We know from the pandemic the increases in the number of emergency department visits. We know that the symptoms of anxiety and depression in our young people have been escalating for nearly a decade. We've known this, that we've had a pandemic of mental health challenges in our children even before COVID-19. COVID-19 made things significantly worse, and it highlighted it. And in fact, in some ways, it brought out people from the shadows to talk more about their mental illness. However, at the same time, that this is not something that is new. This is something that we have been dealing with for years, and it is something that we will continue to deal with. As the reality is that our nation, our world has changed so dramatically. We are now getting, in the immediacy of the feedback that's happening. You go online any second and you can be bullied, or the things that happen like this. And that's what our young people, my grandchildren, are going through at this very moment. And these are important things to talk about. What do you do with young people in terms of social media? And we'll get to that in a second. The one thing that I'm proud of about the work that SAMHSA has done is to create this national strategy. And under President Biden, there was a national mental health strategy that talked about increasing connections to care, supporting Americans by creating healthy environments, and strengthening our system capacity. And SAMHSA took that direction and that vision to create its own SAMHSA strategic plan from 2023 to 2026. Those of you who are here that are sort of policy wonks and stuff, I urge you to download this, because all the things that you're talking about, the importance of work in schools, the importance of the integration of care, are all part of this. For me, this was the first time in my tenure in government that SAMHSA or any federal agency actually highlighted and created a priority for children, youth, and families. There were 5 major priorities that were covered by SAMHSA's strategic plan, and this time one of them was specific to promoting resilience and emotional health for children, youth, and families. And that was, I give SAMHSA a lot, and Dr. Delphin Rittman, the Assistant Secretary, tremendous amount of credit for that work and for allowing the staff to focus on what will be important from a child, youth, and family perspective. All right. I almost took this slide out earlier because I've been talking about federal budgets for many, many years, and I decided to leave it in for a reason. The president's budget for 2025, which I think all of you know is not going to happen. And at the same time, that it's worth noting that some of the programs that we care so deeply about, and I highlighted, if you can look at the Children's Mental Health Initiative, or CMHI, which is what we call in the federal government the systems of care approach. And that program started in 1993 with a $4.9 million investment as a demonstration program at SAMHSA. $4.9 million. And over the years, that program had bipartisan support, so that when I left SAMHSA, the program was at $130 million a year, and the president actually called for an additional $95 million for this fiscal year budget to make it a $225 million program. That would have been pretty cool, right? I mean, and that, I know people want to clap for this, but don't. Because it ain't going to happen, right? Because we're going to be looking at serious cuts. What we do know is that the whole concept of this actually does work. So the roadmap is really important. And so where do we go from here? This is the key element. So we can sit up, and people have talked about the challenges that we've experienced, but we really do have to go somewhere from here. Where do we go? Well, first of all, I want you to look at this screen. I can't actually see if this is working or not, but does anybody notice anything about the screen? Yeah, those dots are kind of jumping around a little bit and everything. Yeah. Why would this former federal employee want to, give you a headache with all of those dots? I do this because I like, as our former speaker, I like metaphors and stuff. And the idea here is that these dots are somewhat randomly jumping around. And this is the kind of experience that our children, our young people, and their families go through when they need help. Where do they go? They don't know. Oh, you go over here, you go over there. They are actually, jumping from dot to dot, trying to find the services and the care that is necessary in order to hopefully keep kids in their families, in their communities, and thriving. And so what it is that we need to do is, you too can do this if you have a 25-year-old helper. Is that we have to connect all of those dots, and we got to connect the dots by maintaining a focus on youth and families at the center of everything we do. And then, as they say, wrap around the young people and their families, or surround them. I know wraparound's gotten a lot of terms, a lot of use lately, but surround them with the things that are most important, like schools and work approaches and faith organizations and other young people and families, as well as our primary care providers and our policymakers. So the idea is to take what was sort of, meaningless and make it meaningful by connecting the dots. And that's what you all are really doing here today. So the real meat of what I want to talk about, though, is within system transformation. System transformation is a tough thing. Like I said, we've been working on creating these systems for decades, if not longer. And we've done a really good job of doing this. And when times get tight and things get tough, what do people typically do? Well, rather than actually working together and collaborating, people will retrench. They will go back into their silos, and they will try to find ways to protect what it is that they think is theirs. And so I wanted to really point that out, because this is going to be the time when we need to expand our ability to work with others, when we need to think about children in a much more holistic way. And we did this, and I've done this over the last several years through what we called our transformation equation. V plus B plus A times CQI squared. This is where I drop the mic and go, yeah, that's great. But what it really means is very simple, that in order to transform your system, we all have to be on the same page. So transformation actually equals your vision. Vision is what provides the direction for the work that you do. And whether it's at the national, the state, the local, county, or the very local level, the people that are doing this work have to have a shared vision. We heard before about the shared leadership approaches. That's absolutely true. You have to have a shared vision that you're marching in the same direction. Your vision has to be accompanied by a belief system. We in this room are on the same page. We understand that our beliefs involve that we want to involve our families through family-driven or youth-guided care. We want to approach our cultural and linguistic competence as part of our belief systems, our evidence-based practices. And our vision and our beliefs mean nothing unless you take those 3 actions back home with you and implement them, whatever they may be for your community. Because you know what? Your community is very different. I used to talk about how, that rural Montana, the Blackfeet tribe, is extremely different than what is necessary in inner city Chicago or where I now currently live outside of Bradenton, Florida. So all of those things have to be taken into account because all of our systems are different and our cultural activities are different. And so we have to do this. And we multiply all of that by continuous quality improvement squared. Well, CQI is, if nothing, is about getting feedback from the people that we need to get the feedback from, whether it's providers, most especially our young people and our families themselves. We square it because that is one of the most important components of changing our values, beliefs, and actions. We don't change them unless we get the data and the information necessary. I'll give you a small example myself. I was a clinician. I was taught to sit back in my couch and stroke my beard, which I didn't have at that time, and say things like, very interesting, and then I learned that it was much better when I actually went to the person's house myself, or that I actually engaged the family and seeing what would they like to see as a positive outcome for this. So my vision and my belief system changed as a result, even though I was trained in a different way. So that's the transformation equation. And now what is it that we transform to create these seismic shifts? Well, we create transformers all over the country. All of you are transformers. I was hoping there's a lot of young people in the room because they would get this. Those of you who don't know, anybody know who that car is? Bumblebee. Whew, okay, it didn't go over as worse as I thought. So we really want to transform these systems. All right, so how do we do this? I'm going to talk about 5 areas that I think that if we transformed would become the seismic shifts that are necessary to improve the outcomes for our young people and their families. Let's take number 1, integrated care. That's what this conference is all about. That's what we tried to do in our SAMHSA strategic plan and our report. You can see the concept of systems of care and this integrated approach is really critical. But my system of care, my integrated approach and what I look at systems of care has changed over the years, very much so, because I got feedback from folks. So I want to start by talking about our mind and body connection. We treat the brain differently than we treat the body. In fact, if you look at this slide from my colleagues at Meadows, we actually take the head off and we treat over here, but we take our physical health side and do it over here. And that is absolutely not working. And I have a personal example of how we have to combine the efforts to treat this. So if you're squeamish and we're right before lunch, I apologize, but get ready for this. But I had a couple years ago, I woke up looking like that. I was scared, okay? I was really scared. And I was having a physical health crisis. I didn't know what to do. If I was having a mental health crisis, what would we have said? Go to the emergency room, right? That's what it's. But instead, I ended up calling my primary care physician. So there you go. I called my primary care physician. You know what he did? He asked me to text him a picture of my eye. And then he said, you know what? You better get in right now. So I went in there. And he said, I'm not really sure everything that's going on. He got on the phone, he called an ophthalmologist, and he got me an appointment that afternoon. I went to the ophthalmologist, and he said that all of the little, you get a sty in your eye. Apparently you have about 44 glands on your, and all of them were infected. Ugh. All right. So what ended up happening, though, is I didn't have to go into the hospital. I didn't have to sit in an emergency room for 6 hours waiting to get an evaluation. I got antibiotics, and I was able to get better. And that's the way it is. But when you have a mental health crisis, what happens? Well, number one, you're told to go to the ER or the hospital. Number two, if you're unfortunate, you may actually get law enforcement called on you, and you get taken away, to jail or in handcuffs. And that's not the way that we want to do our business. So what we need to start to do is we need to actually look at our primary care providers as a way of an ideal system where we put the head back on top of the body. And that's where I think, for me at least, I've become a much more of a proponent of engaging with primary care. That 75% of parents and caregivers go to the primary care provider first when they believe that their child has some type of a mental or behavioral health issue. 75%. So if we can help our primary care offices take care of the mild to moderate symptoms, we will free up a lot of time in the rest of the system to make this work. So that's sort of the goal, is to create a much more of a public health approach to this. And in fact, at SAMHSA, we supported a monograph by Georgetown that actually is called A Public Health Approach to Children's Mental Health. It is a conceptual framework that integrates this concept of doing these things. All right. The other thing that is that in addition to expanding our role, and so when you guys are talking out there about partners for your systems, please include primary care, whether it's clinics, whether it's nurse practitioners, whether it's general docs or pediatricians or physician assistants. You know what? We're all in it together, and it's the mind and the body needs to be connected to each other. Systems of care is a way to do that because it allows us, it has a framework, it is an approach that creates the infrastructure necessary. And infrastructure is not a real jazzy term or anything. What it does, however, is that it creates the ability for you to do your work. And the system of care, and again, it's the idea that we're coordinated. We create coordinated networks, and we build meaningful partnerships with a whole host of groups, especially young people and families, and focuses on cultural and linguistic needs in order to help families function better at home, at school, in the community, and throughout life. It is not a prescription. Systems of care can be different across everybody's, wherever you live, whether it's in Yolo County or San Bernardino. It's not a prescription. It is a framework that can be flexible and adaptive, and also has an idea of a philosophy that we can use. And what it does is that brings together the Olympian spirit of our rings of circles, all right? Child welfare, behavioral health, primary care, education, juvenile justice, all coming together under one umbrella. That's why I love that idea when people talk about a children's commission and creating high-level support for the work that we do. And we know that this works because of decades of research that we were able to accomplish at SAMHSA, showing in reports to Congress and other things, showing that when young people are going through a system of care that have serious challenges, their behavioral problems are reduced. Their attendance at school goes up. Their grades go up. Their ability to have relationships they reduce suicidal ideation. And they stay away from, they have a more positive contacts with law enforcement rather than some of the negative ones, as well as reduced substance abuse. Our goal was to create an environment where the outcomes were that children are healthy, at home, in school, and out of trouble. And I unabashedly stole that from a colleague in Oregon. Okay, and I want you to know that because every one of those, whether you are a pediatrician, you care about, being healthy. If you are a child welfare person, you want kids to grow up in their homes and to be safe. If you're an educator, you want outcomes related to them being in school and graduating and, things like that. And if you're in juvenile justice, you want your kids to stay out of trouble and out of detention centers or out of the jails. So that's where we're headed, at home, at school. All right. The System of Care approach, a recent or 2020 monograph that Beth and I and our medical director did. We can get you the copies of all of that. Number 2, school-based and school-linked services. We've had a lot to talk about related to this here. One of my colleagues at SAMHSA told me once, Gary, when kids are too mad or too sad, they can't add. It's as simple as that. Dr. Lark Wong, she was amazing and also a great mentor as well. I talk about both school-based and school-linked services because you can't do everything in schools. You have to link some of that. So in rural counties, you're not going to find enough psychologists or social workers or even a psychiatrist. So you've got to do these linked services. And the government has been supporting this idea of a comprehensive school mental health system. If you have not seen this particular report, I urge you to see it. It talks very much about those relationships using MTSS, multi-tiered system of supports, as the framework around how to do this in school settings. We also know that the whole child health models are working. My colleagues at Nemours Hospital are working on an alliance now across all of those. Texas, where I was for a couple of years, has an amazing telehealth program that allows that, with parent permission, with a referral from anybody at the school, allows for an immediate telehealth visit with a psychiatrist or a psychiatry resident from one of the 12 medical schools. And it allows them to do an assessment, brief therapy, and then referrals for services. And these are actually working. Significant reductions in depressive symptomatology, that it's been across the board. Lots more information. But telehealth in schools is something that I believe is going to be expanding and going into the future. We could talk more about the crisis continuum. One of the things that I'm most proud of that SAMHSA released while I was there the last time is national guidelines for improving youth mental health crisis care. And that's something that you all can draw down. And as you're thinking about your own system, how many youngsters could be served by mobile crisis services or telehealth? Those are the things that are going to be on the future. SAMHSA created, of course, with legislation 988. We know that since its launch in July of 2022, SAMHSA has now answered more than 10 million calls, texts, and chats. Guess who uses texts and chats? Young people, exactly. So those are the things that we are doing. And now, a year after that, SAMHSA has rolled out the addition of a Spanish component for text services as well. And that continues to expand, and it's really pretty amazing. I wanted to harp a moment on youth and family peer support just because of the way that this conference has evolved. I think that continuing to generate excitement out of our young people, their advocacy approaches, they can say a lot of things that really get attention more than a former federal bureaucrat can do, or even some of you, and that they can do and speak. And oh my goodness, did you hear Claire, Saran? I mean, they're articulate and passionate and make really good speakers at legislative conferences. Just saying. So youth peer support and family peer support are the areas that I think that we have to continue to expand on. I mentioned the idea of Youth Move. Every community should have, at the very beginning, we had these, acknowledging the youth advisory boards. And those are the things that we can do, I believe, across the country. The fifth area that we have to focus on is our brain science and technology. We are learning so much more right now about brain capital and the use of technology. My daughter, she's a physician in Philadelphia, and they're now incorporating into their medical records the ability to use AI. You set your phone up and you use AI to write your notes. Could you imagine the amount? The folks at Abridge say it saves a physician 2 hours a day by being able to do that. These are things that, there's danger within the technology, and there's also great opportunity within the technology as well. SAMHSA, as a result of the Harris and Biden administration's actions to protect youth, ran with the Department of Commerce a Kids Online Health and Safety Task Force. That was, I put a little link in there so that when you get it, if you're interested to know about the recommendations related to that task force, that it will be in the report that came out. And now the state of the science related to youth and social media, we've got the Surgeon General's advisory on youth and social media. And I also wanted to call out, and although he's not here today, a very good friend, Steve Adelsheim from Stanford, who's been working here on expanding work, especially around early psychosis. And he and two of his colleagues just edited a book that came out called Social Media and Youth Mental Health. We need to focus on this, folks, because it's not going away. And our young people, at what age is it okay for you to give your child a phone? Yeah. So pretty much never, 25, 6, I don't know. It's all this. My daughter just experienced this with her 10-year-old. My oldest grandchild, he's going to middle school now. And now at what point do you do all of this? So there's a lot of work being done to address youth and social media. If you're interested at all, SAMHSA has created a new center of excellence on social media and mental well-being. And there's a website there. One of the coolest things is that you can literally type in and ask a question and get a response from one of their experts, whether it's a pediatrician or psychologist, one of their social media experts, and you can do it right online, right on that thing, so it's all good. So you guys are all really focusing on making one system, making it real together, transforming those visions and into those different areas. And so I had a few parting thoughts for you as you're going forward. First thought, you got to add more buddies to the system. So whatever you do, whether it's if you're in a community and you got a bunch of kids that are getting in trouble, you got to bring in the probation officers and the judges, and you got to go with the police department, and you got to do all of this. So please think about it. And for me, you got to include your primary care providers. All right. Number 2, or the next thought, you got to create win-win situations. And I'm not talking about that. I'm talking about what I need and what you need. Win-win is important so that everybody at the table can actually get something out of this, right? I think the whole idea is to do that. The other thing that I learned from one of my former bosses at SAMHSA, a presidential appointee, Charlie Curie, was that to be the aspirin, not the headache. I have to say, I was a headache. You could probably tell I'm a little bit of a headache. At the same time, he's like, Gary, I need you to be the aspirin. Come with solutions, come with problems that we can actually work on together and do that. I think that those are critical pieces, being the aspirin and not the headache. And then sometimes remember, within your own comfort level for your own risk factors or whatever you want to do, is that sometimes you've got to cause a stir to stir a cause. And when you think about that, it's a really important component in order for everybody to say, we've got to do things. You can't just let it go. You got to be out there advocating and doing all of those things. Now, folks, you got 500, 600 people, and there's great power in this room. It's amazing. And you know what comes with great power? You already know that. So in my last second, I'm going to say it is now time to get busy, to take those things back into your communities, make those plans, implement those actions, and get to work. It's as simple as that. So y'all what? If you want to follow me or join me on LinkedIn, that's what I do now on LinkedIn. Otherwise, thank you very much for giving me this opportunity.
I am so proud that California is breaking barriers that so often prevent caring adults, teachers, counselors, mental health providers from being able to effectively for our children and youth. As Gary so vividly described, the system we've inherited often stands in the way, and we have to reinvent that system to enable better approaches and better outcomes, both in our schools and in our mental health systems. And I'm going to talk about both and how we are really approaching this transformation in California. In a certain way, educators with families are actually the primary care providers. And if we do that part of the work well, then the additional support from mental health professionals will be more effective and more less needed in every instance and more effective when it is needed. I want to just start by saying that I started out my own career as an English teacher in a big factory model high school, actually two of them in which I taught. I had 180 students going by every 45 minutes, 30 students at a time, 180 students altogether. I was not working in a team of other teachers. I did not have any kind of a personalized opportunity to work with my students. There was one counselor for 500 students, and I cared desperately for my students. For each and every one, I worked as hard as a human being can work on their behalf, but I could not care effectively for them in that structure. And that is part of the problem we have. You've heard about the problems in the mental health system and the structural issues there. We have structural issues in our schools as well. We have to transform both of them and bring them together, not just running from dot to dot and connecting them, but changing the dots, so to speak, so that we have a system that really can work for students. In my first year of teaching, I taught the students who had failed English the year before, because who else would you give them to but a beginning teacher? And I had some amazing students, but it took a lot of work to get them to believe in themselves and to begin to really engage with the material. And I remember two of them in particular. One of them never wrote anything. He would sit back in his chair initially, but he finally got engaged in the kind of work we were doing, and he began to write in response to the things that we were working on that were connected to their lives in various ways. When he finally wrote something, he had the tiniest script. You could barely read it without a magnifying glass, but it was brilliant. And he wrote more and more and more, and he was really on the way, I thought, to becoming a publishable author someday. All of a sudden, Jeff disappeared. I couldn't find him, couldn't get a phone call back from his home. I finally went to the office. I said, do you know where he is? What's going on? He'd been expelled for substance abuse. Nobody had even bothered to tell me as his classroom teacher because the bureaucracy was just moving ahead, doing what it did in its fragmented way. There are lots of ways we could have prevented that from happening. And the same thing was true of another student I remember who sat in the back of the classroom quietly, very personable and patiently. And I discovered halfway through the year that he couldn't read, and that nobody had flagged that. Nobody had gotten him the resources or the help that he needed. And I had nowhere to send him. I did the best I could to tackle that with him myself. But there are lots of reasons why we need to reinvent both our schooling systems and our mental health systems and the way they interact. And I want to talk to you about how we are doing so in California, both in our education and our healthcare systems. I'm going to take a minute to plug my computer in, because I see that it is about to be out of juice just at the right moment in time. There we go. Hopefully we can stay together for the next few minutes. So as I noted, our current schools were designed around the factory model. They were designed to pass students along an efficient assembly line. They created in the early 1900s, when Henry Ford had created his assembly line, which was the model for the high school. They created the age grading system where you go to a different teacher every year, the platoon system where you run in the high school or the middle school to a different teacher every 45 minutes. Teachers were individual workers on the assembly line. Curriculum was prescribed and still appears in our pacing guides and, in our systems of curriculum. Tracking was designed and was actually explicitly designed to create different conveyor belts for students based on race and class, because the eugenicists were very much involved in the redesign of schools in the early part of the 1900s, and they had very specific ideas about who could do what kind of learning and what kind of work. And then schools were designed to select and sort rather than to develop talent, which has created a very competitive, high anxiety system, which also, among these other things, creates both anonymity and anxiety as parts of the school. A national survey of 6th to 12th graders found that only 29% felt that their school provided a caring, encouraging environment. Most did not feel that there was an adult who knew them well in their school. Again, part of the design of that factory model. There was a new survey about 2 years ago of 21,000 high school students that found that 75% reported feelings about school that were negative, including the most common ones: tired, stressed, and bored. So we're developing mental health issues even as kids are experiencing mental health issues outside of school. And all of this is associated with that school design. So the question is, how can we really reinvent the schools and the systems that allow us to get to learning and thriving? As I've noted, we have to reinvent because our schools were not designed for relationships, for a whole child approach, for 21st century skills and deeper learning, for personalized supports, or for equitable opportunity and achievement. And our very heroic educators are working within these systems, trying to make them do things that they were not designed to do. As Gary said, our systems are producing the outcomes that they were designed to produce. We have to change the systems if we want to change the outcomes. California has engaged in a transformational response in the education space in this administration, which I've been proud to be a member of in my role as president of the State Board of Education. We have introduced universal meals, universal preschool, expanded learning time, after school and summer programming, investments in mental health, $4 billion in children and youth mental health, social emotional learning and restorative practices. We've invested in educator preparation for whole child practice so that teachers and leaders understand the ways in which children need to be supported. And then more than 2,000 community schools have been funded. Again, another $4 billion initiative. All 58 counties are involved, trying to organize schools to support the whole child. So the community schools are one piece of the effort to transform the purposes and the designs of schools. They have these 6 major features. 4 of them are pillars that were written into the law: expanded and enriched learning opportunities, learning in school and beyond, after school and in the summer, in ways that are enriching and exciting and joyful, collaborative leadership, shared power and voice with families and with community partners, including but extending beyond mental health providers. Rigorous and community-connected classroom instruction has been added to this so that we're paying attention to how in the school we're helping kids be connected to their communities and in settings that are culturally responsive, integrated systems of support for health and mental health. A culture of belonging, care, and safety is built into our legislation in California. Community schools not only get to add mental health and health services and academic services of various kinds, but they also are charged with integrating social and emotional learning and restorative practices, which have a huge effect on whether students feel a sense of belonging, care, and whether they get help to deal with challenges that are threatening their mental health, or whether they are sent into worse challenges by the way the school behaves. And then, of course, powerful student and family engagement. At the same time as this has been going on, the Children and Youth Behavioral Health Initiative, fondly known as the CYBHI, it's a pretty bad acronym, but it's a very good program, have been transforming together, trying to create a redesigned ecosystem for integrated, equitable, accessible, and community responsive support. And that includes both a shared vision, empowering families, committing to address the root causes of structural inequities, the structure, organization, and resources integrating those resources and those structures, bringing mental health providers into schools and into spaces that are community accessible, and then transforming the function, processes, and outcomes by coordinating care and not asking families to run around, from dot to dot, trying to figure out how to get what they need. That is also the mission of community schools, to integrate services so that they're made readily available. All of this builds on the principles we know from the science of learning and development. We now know a lot from neuroscience, developmental science, learning science, about how people grow and learn. And if we work with those principles, we get much better outcomes. We know the brain is always developing. It's not baked and done when you're born. It's still developing at my age as a product of relationships and experiences. So how we design relationships and experiences matters greatly for the development of the infrastructure of the brain, as well as for the way in which it's used. We know that learning is social, emotional, and academic, and that these are completely linked. That if you're in an environment where you feel trust, where you feel competent, where you're not stigmatized, where you're in a group that is working with you, you learn more. And if you are traumatized, if you are anxious, you learn much less. And so this is not a frill. It's part of the pathway to academic achievement. We know that children actively construct knowledge and meaning by connecting what they know to what they're learning. And that always happens within cultural context. So we need to be educators and mental health providers need to be aware of and connecting to the way in which children are experiencing the world. We know that inquiry and connections are what jumpstart thinking. And so we need work that is engaging in that way. Students' perceptions of their own abilities influence learning. So schools that enable students to feel confidence as well as develop competence are making a difference, both in children's mental health and in their learning. We know that trauma and adversity, of course, affect learning, but that relationships are key for healing. So we have to create environments in which those relationships are readily available. And we know that a young person's best performance occurs under conditions of low threat and high support in settings where they're accepted, respected, and enabled. In community schools, we see that in the first couple of cohorts of those schools, that most are really building a positive and restorative school climate as an explicit part of their work, along with collaborative leadership and integrated student supports. We know that in schools that have done more to adopt restorative practices, which begin with building community and community circles and community meetings, and extend to figuring out ways that students can make amends if there's a problem and rejoin the community, that there's less misbehavior and gang membership and victimization. There's also fewer depressive systems, sleep deprivation, less illness, less substance abuse, fewer absences, higher grade point averages, better school climate. So we can engage in mental health supports simply by creating these kinds of programs in schools. And we know that the partnerships are growing rapidly, and community schools are decreasing chronic absenteeism rates, both by reaching to families and helping them solve problems that prevent students from attending school and making school a place that is better to attend. Among the funding sources for this are not only the state program for community schools, but also a third one down, the Children and Youth Behavioral Health Initiative, which is part of this transformation. In that initiative, we are both providing support for teachers to learn about ACEs and to be able to help children with toxic stress, and bringing the voices of young people forward for mental health professionals and educators alike. It is here, there, and everywhere. It takes an all of the above approach for bringing behavioral health services to the healthcare settings, education, digital environments, homes and communities in a variety of ways. We've invented a new role, the certified wellness coach, who can be available both in school settings and in other settings to support problem solving and wellness development for individual students, but also groups of students who are working in classrooms or in communal settings, or who are sharing certain challenges or problems together that they can work through. So in these different settings, we're bringing wellness into the classroom, nurturing a supportive campus culture, expanding access to school-linked healthcare services, as well as behavioral health online, and then working with families and building a community-based workforce that can connect better to communities. Holding youth at the center and equity as foundational. In fact, youth are designing new mental health and wellness support centers. So we're actually seeing both the voices of youth and the ideas and intelligences that they bring informing the system. Finally, I just want to mention another unique partnership that is between healthcare and education. It's called CalHelp. It works to embed social and emotional learning in communities. It's all across the state with multiple sets of partners on the health side of the system, as well as the education side of the system, again, to integrate the kind of social and emotional learning that lets everyone thrive from the beginning and is part of the effort that we have to successfully redesign schools. I won't go into all of these features. You can find them on the Learning Policy Institute website if you want to, but getting to a safe, inclusive school climate is one of several things that allows us to transform schools. One piece of that is that we need structural changes from what I described at the beginning of my talk, seeing 180 kids, in 45-minute periods coming through 6 times a day is not an adequate way to care for children and for youth. One of the things many schools in California are doing is creating small learning communities, putting in place advisory systems in which there's a family group that meets with a teacher or other adult every day to do social emotional learning, to engage in community circles, to get academic and mental health supports, to do distributed counseling, as well as building in time for the family connections, for teaching teams to meet around children, to connect to communities in ways that allow kids to feel like the school is not an alien part of the community. I'll close with the sense of what goal ought to guide us as we're designing these transformed systems. Years ago, John Dewey put it, I think, very well when he said, what the best and wisest parent wants for his or her child, that must the community want for all of its children. It's only by being true to the full growth of all the individuals who make it up that society can by any chance be true to itself. I know that is what you are working on in this conference and in this setting. It is what we need to be thinking about in all of our systems, not just to make them coordinate a little bit better, but to transform them so that they are essentially supportive of thriving for every one of our young people. Thank you.